My name is Ayalew Tefferi. I am a consultant hematologist at the Mayo Clinic, Rochester, Minnesota. I'm a professor of hematology and medicine, and I am going to talk about an article that's already online in the Mayo Clinic Proceedings. It is entitled Myelodysplastic Syndromes, Many New Drugs, but Little Therapeutic Progress. And it concisely summarizes the current state of the art in the disease itself and its current management. Myelodysplastic syndromes is a form of blood cancer which is serious because it shortens survival and it has a high risk of transformation into an even more serious blood cancer called acute leukemia. Now, having said that, there are 2 points that need to be made. The first is that not everyone with myelodysplastic syndromes is at the same risk of transformation into acute leukemia or the same risk of shortened survival. We use a number of laboratory and clinical features to distinguish which patients are at a higher risk of this adverse outcome. And in that regard, the 2 things that we look at primarily are the type of cytogenetic abnormalities seen in the bone marrow, and the second thing is the number of blasts or immature blood cells that are seen either in the bone marrow or the peripheral blood. The second point that needs to be made is that not everyone succumbs to leukemia when you have a myelodysplastic syndrome, and there are other major complications outside of transformation into leukemia, and they include bleeding because of very low blood count, infections because of very low neutrophil count, and many people require heavy transfusions, sometimes every month, sometimes every 2 weeks, and this greatly jeopardizes the quality of life for many patients. When it comes to drugs, we really have not made that much of an advance in the last several decades, other than perhaps one drug called lenalidomide, which appears to work very well in a very small subset of patients with myelodysplastic syndrome, in whom there is a single cytogenetic abnormality called deletion of 5q. And those patients, low-risk patients with 5q deletion abnormality, can expect to become transfusion independent and have some remission of their disease for up to 2 years and sometimes longer. However, the drug has not been shown to improve survival, so we don't really know the effect on survival. And also, the drug's activity is very limited if you have a high-risk disease, unless in the context of the high-risk disease that you only have a single abnormality of deletion 5q, and that you do not have low platelet counts, defined as a platelet count of below 100,000 per microliter. Outside of this drug, for this specific effect on making patients transfusion independent, many of the other drugs are usually sold as a hype rather than true value when one compares to what has been available for the last several decades. And this includes actually 2 specific drugs. One of them is an iron chelator, and iron chelation in general has been found to be very helpful in improving survival and decreasing morbidity in patients with congenital hemolytic anemias such as thalassemia. But in patients with myelodysplastic syndrome, there are 2 major problems, and that is, first, nobody has shown that iron overload substantially affects either survival or quality of life in these diseases. I have a very large group of, a very large practice of patients with myelodysplastic syndrome, and I rarely see iron overload as being the cause of death or morbidity. The second problem is, even if that were the case, one has to prove that a new drug can alter this risk, and there has not been a single proper randomized study to show that iron chelation is better than no iron chelation in patients with myelodysplastic syndrome. Most of the reasoning is based on extrapolation from patients with thalassemia, and that is not very appropriate because this is an extremely expensive drug with potential side effects, including renal failure, and one has to do the appropriate controlled study before pushing such drugs. The other drug is in the group of drugs called hypomethylating agents, and the problem with those new drugs is nobody has really shown in a proper randomized study that has the appropriate randomized arm, such as high-dose chemotherapy or low-dose cytarabine, properly designed to answer the question whether these new drugs do better than the old inexpensive drugs. And that's what the commentary tries to do, is try to summarize these issues in a manner that is not biased by any industry influence. Unfortunately, and that's the main message of this commentary in the Mayo Clinic Proceedings, we have not really made major advances in drug therapy for myelodysplastic syndromes. At this point, allogeneic stem cell transplantation remains the only treatment that can potentially cure patients or make them live longer. Obviously, allogeneic stem cell transplantation has its own issues. There is increased mortality and morbidity, which is associated with graft versus host disease and other treatment-related complications. And we usually like to select the patients in whom these risks are justified. In general, patients that are younger than age 65 and have a higher risk of disease are potential candidates, provided they don't have too many comorbid conditions and provided they have an appropriate donor for the stem cell transplantation.
We hope you benefited from this presentation based on the content of Mayo Clinic Proceedings. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you're interested in more information about Mayo Clinic Proceedings, visit our website at www.mayoclinicproceedings.org. There you will find additional videos on our YouTube channel, and you can follow us on Twitter. For more information on healthcare at Mayo Clinic, please visit www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.